somewhere beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter. As a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.
Good morning, good afternoon, and good evening from wherever you may join this session. A very warm welcome from my side. My name is Kai Herensky, and I'm the Global Medical Lead of Baxter's Acute Therapies and Specialty Monitoring. And it is my great pleasure and honor to be your host for today's session. Before we get started, I would like to introduce my colleague, Hani Salah, to you. He is the commercial lead of the EMEA region, and he would like to welcome you as well. Hani, please.
Thank you, Kai, very much. Good morning, good afternoon for everybody. I'm very happy to be with you today. My name is Hani Salah. I am the Vice President of Baxter for EMEA region. And on behalf of Baxter, I would like to welcome you all in our 8th symposium, which is a symposium that we have been doing for a very good period of time with a great result as part of our responsibility as Baxter to train and educate and share the best practice across the world for all our caregivers to support them in doing their job. We have in Baxter since over 85 years now, one single mission, and this mission is saving and sustaining lives. With this, every day, there is millions of patients, caregivers are depending on Baxter to deliver products to support them in sustaining the life of their patient in all different aspects. We are talking about critical care, renal, advanced surgery, surgical operation, also on all the ICUs and IV across nutrition, across all the globe. A great portfolio, which is everybody knows that when you depend on Baxter, you have the reliability, you have the quality, and you know that your patient is in good hands. With this, we are the leader since the past 20 years on the CRRT programs across the globe. We are the innovator, we are the leader, we are the one that is actually supporting as much as possible our patient and you in saving our patient to do your job. And there was a big support happening during the pandemic. Unfortunately, with the pandemic, there was a big need for the CRRT therapies where we were doing our best to support and to deliver all our product across the globe as much as we can to help you and the patient. This is the symposium that we are very proud of, this year we are bringing all experts from across the globe to not only share their experience about CRRT, but also on the blood purification therapies going forward. We have a great panels of people. We have a great group of KOLs joining this symposium with the big expectation that the outcome for everybody will be a better way to serve and support patient going forward. I'm very happy to be able to do this. We used to have it face-to-face. Unfortunately, we cannot do it yet face-to-face soon, and I hope, hopefully with all your help, that starting next year, we'll go back to a face-to-face meeting where we can meet and discuss for a couple of days, not only a few hours over the symposium here. Please enjoy the time, ask all the questions that you want, try to exchange all the experience and see what is happening across the globe as much as possible. We will do our best to make it fruitful a few hours for you. Very happy to be part of this symposium, and very happy to see all of you soon. Thank you very much, and back to you, Kai.
Thank you very much, Hani. As Hani was mentioning, I think we have an excellent panel of speakers from across the globe. This year, the focus is a little more on blood purification technologies, and I think we have a very interesting agenda that hopefully you find interesting as well. For those of you who are joining this meeting not for the first time, I'm always saying this, I very much enjoy being at this meeting as well. This is a very, very diverse region where we have countries that are very rich or very poor, and so clinical practice differs substantially amongst these countries. And for me, it is at times eye-opening to learn how these clinical practices are implemented in the various countries in the region. As Hani was saying, I can only encourage you to please ask questions via the chat function. We cannot promise to ask all of the questions, but we will promise to get as many answers as possible. Obviously, when creating this agenda and discussing with our marketing colleagues, Catalina Tudosa and her team, what the topics could be, we always try to align with what is important for them, and obviously they know this region better. We are looking at AKI in a broader context, so for us this is also part of fluid management strategies, and maybe there could be other topics in the future that you would be interested in as well, such as fluid management, monitoring of fluid management, and maybe the choice of fluid. If there's anything besides the topic that we are discussing today, please feel free to also enter that in the chat so we can get some feedback, and maybe this could be part of the agenda next year. With that, I think we can get started, and it is my pleasure and my honor to introduce our first speaker, who will talk about something that may be, let's say, under-recognized, which is temperature control during CRT therapy. Our speaker is Professor Markus Broman, who is an associate professor at the Department of Anesthesiology and Intensive Care Lund at the University in Sweden. His research focuses on malignant hyperthermia, acute kidney failure, toxic shock syndrome, and hypophosphatemia, and he has authored more than 30 peer-reviewed articles and publications. Markus, please.
Thank you, Kai, and good evening from Sweden. I will today give a talk about a theme that has not got a lot of attention, really. Temperature and heat balance during CRRT. For an ICU patient, we have basically 4 mechanisms giving the result of heat loss from the patient. Evaporation, vaporization of water by sweating, or by insensible lossing from the breathing, for instance, or from a surgical wound. Radiation, emission of infrared electromagnetic energy from the body. Conduction, transfer of heat from the body to an adjacent cooler object. It can also be the air surrounding the patient or the lining surrounding the patient. And convection, transfer of heat to currents of air or water. Of course, hypothermia in a patient can also be a result from certain diagnoses, such as sepsis, for instance, or hypothyroidism. The set point in the human body is about 37 degrees Celsius, and the body has actually limited possibilities to avoid heat and is very vulnerable to hypothermia. And I think that in critical care, warming is basically needed for all patients. Here we see a summary of clinical symptoms appearing when the temperature drops. We go from a hyperdynamic situation with apnea, tachycardia, hyperventilation, shivering. Shivering can consume a lot of oxygen. And then we go with lowering temperature to a hypodynamic situation. And finally, we end in a situation with apnea, coma, and no life. Clinical consequences of hypothermia are many. We can have sympathetic stimulation, which augments, for instance, norepinephrine effect, which causes a burden on the heart and increases the oxygen consumption in the myocardium. Measurement of saturations are difficult and result in erroneous numbers. Shivering, as I said already, consumes a lot of oxygen. In the contrary, hypothermia itself slows the metabolism. The patients become more prone to infection. Coagulation factors work slower, and action of drugs change. For instance, neuromuscular blockers, propofol, etc., have an increased time of action. Also, sedatives and drugs and other measures that we do in the critical care result in themselves in hypothermia, which aggravates the situation, of course. The temperature in human body appears actually as a set of gradients, so that the human body is dependent on the temperature which exists in the room temperature, and we have actually the warmest part of the body in the core, of course, and then we have cooler parts in the periphery. So we could say that we have a temperature map existing in the body, which is dependent on the environment. And we can measure the temperature at different locations. And the method we use gives a little bit different values compared to a golden standard, which we could consider temperature measured by pulmonary artery catheter. However, the methods themselves, if we measure the temperature in the urinary bladder or in the air or in the esophagus, they are quite uniform within the method. However, they differ with the difference to the golden standard, which then, in my opinion, is a temperature measured by a pulmonary artery catheter. So the temperature setting in the human body is not always very easy to understand and to realize. Hypothermia is an everyday issue in the ICU. Mild hypothermia might have advantages in certain cases, but in my opinion, clear evidence is not available, and profound hypothermia must always be considered as detrimental. If we go to the most modern equipment we use for CRRT today, we have a new warmer on the Prismax machine, the so-called Thermax blood warmer, which integrates directly with the CRRT machine. This warmer can be maintained from the interface of the CRRT machine. It can be connected to the dialysis circuit, and then it can be managed through the user interface quite easily. We use this warmer in my clinic. The warmer actually works through a feedback loop. So it takes in a lot of parameters from the circuit and adjusts the warming, cooling in relation to these parameters in order to get a stable temperature as close to the set temperature as possible. The Thermax blood warmer compared to previous fluid warming, it heats the blood directly when the previous blood warming systems actually work as a rubber sock around tubings, and the transfer of heat from the warming system to the blood is not that direct. The Thermax blood warmer is independent from therapy flow rates. It delivers a continuous warming, and it automatically adjusts heating, cooling in regard to the situation of the circuit, and tries to achieve the set temperature as close as possible. So we decided a study to compare the Thermax warmer to the previous system, which is called Prisma Comfort Warmer. Prisma Comfort Warmer is basically a sock around the tubing, and Thermax is the new warmer that I have described. So we had 310 complete patient treatments in the control group, and we had 32 complete patient treatments in the Thermax group. And then we defined that a treatment hour is considered to be in hyperthermia if the patient temperature is below 36.0 degrees. And then we analyzed about 60,000 treatment hours in the Prisma Comfort group, the control group, and about 5,000 treatment hours in the study group, the Thermax group. And then we could see that in the control group, 11.43% of the hours were actually in hyperthermia, whereas in the study group, the Thermax group, 10.06% of the hours were in hyperthermia. The difference here is not very, very big, but it is highly significant, and we see this as a signal that the Thermax warmer can protect against hypothermia in patients receiving CRRT. We can also see other interesting findings in these numbers. We see that 1 hour of 10 in a patient population receiving CRRT actually has a treatment hour that is in hypothermia. So hypothermia is very common in these patients. If we look at the need of bear hugger, we can see that in the Thermax group, the control group, about half of the patients had bear hugger, the warming cover device, at some point of the treatment, whereas almost all patients needed bear hugger in the control group, the Prisma Comfort group. So there is a big, highly significant difference here. We could also see that the mean hours of bear hugger in the study group compared to the control group differed hugely, and the difference is highly significant. Of course, when the temperature goes down for a patient, we start to carry out measures in order to maintain the temperature. So we can actually draw the conclusion here that Thermax is giving the nurses opportunity to do other things than to try and put effort in maintaining the temperature of the patient. Then we look at the difference between the set temperature in the Prisma Comfort system compared to the set temperature in the Thermax system, and the difference from the set temperature to the real patient temperature. And we could see that the difference in the control group was minus 4.4 degrees Celsius, a very huge difference. And in the Thermax group, the difference was only below 1 degrees Celsius. So the set temperature in the Thermax warmer was very close to the real temperature in the patient. Here we could draw the conclusion that the Thermax warmer is showing quite good accuracy. Here we see the whole thing in numbers. The mean set temperature on the Thermax warmer was 37.9, and the set temperature for the Prisma Comfort system was actually 40.9, because the system is so inefficient that the nurses, they do overkilling. They go up to the max in order to keep the temperature. But the difference here between the modern study group Thermax system and the old control group Prisma Comfort system is very huge. In our plans are now to go on with a multi-center study, which will start this month. We will include about 20 centers across Sweden, and we got ethical permission actually very recently to go on with this study. We will have basically the same control group as we had in the pilot study. The pilot study was carried out in Lund in my center. That was a single center study. So we will use the same control group. And then we will aim at about 500 patients in the study group across these centers. And we have actually created an online web CRF in order to make it as easy as possible for the participating clinics to participate in the study and to upload their data. With this multi-center study, we aim at more power and to be able to find how efficient the Thermax warming system really is. So, my conclusions. There is a need of more effective and accurate warming techniques in the ICU. Almost all patients cool down. In CRRT, we take blood outside the body, about 1 blood volume per half an hour. Of course, there are a lot of heat losses in the circuit. So it's really easy to understand that there is a large cooling effect for these patients. So the warmer and the warming system is very important. Thermax is a new technology that we have in use at my unit. It has improved the heat balances for our patients, and it has also lessened the workload for the nurses so that they can focus on other things than to keep the patients warm. With this, I thank you for your attention.
Thank you very much, Marcus, for this interesting, I would say, almost new paradigm or paradigm shift. There's two questions from the audience. One is, how prevalent is hypothermia in ICU patients?
I believe that the prevalence that we got in the CRRT patients can be quite well generalized to all ICU patients. I think that maybe 10% of the hours spent in the ICU is in hypothermia for critically ill patients. When the patient stabilizes, they can maintain their heat balance better. And then, of course, this fraction of hours spent in hypothermia will go down. This is my view. There is not much data on this available, actually. So if somebody in the audience will start a study, it is very much welcomed.
It seems somewhat under-recognized, as mentioned before. There was another question: is hypothermia correlated with mortality? Are there any correlations?
There are some studies that find signals of correlation, yes. The situation is very complex, in my opinion. Mild hypothermia for certain diagnoses might also have a protective function. So we cannot generally say that all hypothermia is detrimental. But if we start to go to lower temperatures, then we know, of course, that then we have a situation that is not good. So my answer is there is not much data on this, but there are signals that hypothermia correlates with higher mortality.
Marcus, you mentioned that also, for the dissolvement of certain substances, this is obviously temperature dependent. Are there any, let's say, changes in clinical practice that you think would be necessary, or consequences in clinical practice when we consider what you just mentioned?
We monitor the patients very tightly in the ICU. We know what the situation is. We try to maintain the mean arterial pressure. We try to maintain the coagulation status and so on. And hypothermia will, of course, affect our measures. But to go through here how and what will happen, that is a very long story. But hypothermia for sure affects almost all body functions and affects the homeostasis quite much, in my opinion. And also analysis devices that we use in the critical care are actually built for a temperature of 37 degrees. For instance, the blood gas analysator cannot give a reliable result if the blood is too cold.
Thank you. There is another question that is related to that. What other precautions can we make to prevent hypothermia? Is the CRT dialysis dose related?
I think that we need a good warming system that is integrated to what happens in the circuit, so that the warmer can follow the CRR treatment itself. And of course, we need a skillful team that can understand and put in measures to maintain the temperature of the patients, like increasing the room temperature which is done for certain patients, for instance, for burn patients, to realize, let's say, put it this way, to understand the physical mechanisms that I described in the beginning of my talk, and to realize how and in what way they are active, and try to prevent heat loss from the patient, to understand where and by what mean the patient is suffering from heat loss, and to plug this loss.
Thank you. Any other question? If not, I would like to thank Professor Broman again for his excellent presentation, very clear. And we move on to the next topic and our next speaker, who really doesn't need an introduction. I believe it is truly my pleasure and my honor to welcome Professor Ronco to our symposium. He is, and it's also an honor for us that he's not here for the first time. Professor Ronco is the director of the Department of Nephrology, Dialysis and Transplantation. He has authored on numerous publications, I believe more than 1,065 books, 86 book chapters. He's editor-in-chief of Blood Purification Contributions to Nephrology, and editor emeritus of the International Journal of Artificial Organs. He is one of the most leading experts in the field of acute and chronic kidney disease. And Professor Ronco will talk about extracorporeal blood purification for critically ill patients with sepsis or COVID-19. Professor Ronco, please.
So thank you very much. I am going to share my screen, I suppose, or are you going to do it?
Professor, we've managed to share your presentation from our side, and we can move it across for you if you like, unless if you want to try and share your screen.
Let me see. Okay.
Okay, we've got them. I'll bring them up.
Okay, so do you see my screen? Yes, you do. Right?
Yes, please proceed. Thank you.
Okay, so thank you very much, and I'm very pleased to share my view about the importance of extracorporeal blood purification for critically ill patients with sepsis and COVID. And I've been asked to cover a little bit the importance and the role that the oxalis membrane can have in this area. These are my disclosures. As you can see, it's quite numerous, but this is a kind of guarantee of a perfect balanced presentation. I'm gonna mostly present the rationale for the extracorporeal blood purification and the utilization and characteristics of oxalis filters set in sepsis and in patients with COVID-19. Let's start with sepsis, where a cascade is the rule starting from infection and activation, especially in case of gram-negative bacteria, of CD14 receptors that recognize the complex LPS plus LBP and activate a series of messages up to the activation of nuclear factor kappa B. That in turn activates the monocytes, leading to a series of effectors that have impact on the endothelium and several different organs that may suffer from a specific damage. This somehow depends on a general concept of immunodysregulation that in fact may be due to a very high level of inflammation that somehow depends on the innate response and the activation of inflammatory patterns that may, in one side, lead to death or intractable inflammation. On the other side, may cause a hyperreaction of the adaptive immune system, and the late deaths may be due to immunosuppression and recurrent infections. So we have a clash of mediators. Some of them are pro-inflammatory, some of them are anti-inflammatory, as in the case of interleukin 6. And what is probably needed to go towards recovery of organ function and mitigation of septic symptoms and signs is to achieve a sort of immunological support and a level of immunohomeostasis that allows the system to reconstitute a balanced response.
I'm sorry, Professor, I'm going to have to interrupt you. We can barely hear you, so we want to try and sort out your audio, and people are waiting to hear what you have to say, but they can't hear you because you're not facing the microphone on the computer. So if you can sit closer to your microphone, maybe we can hear you better.
Okay, but this is the microphone I use for 1,000 different webinars, so you have probably to regulate the system because the microphone is perfectly functioning.
I understand that, sir. Just one moment. If you can just perhaps sit a little bit closer to where the microphone is so that we could hear you.
If I get closer to the microphone, I'm going to eat it.
Okay, thank you.
The test of the microphone was perfectly in the range.
All right, that's better that you're closer now. Please proceed, sir.
So we had an attempt to modulate inflammatory response in sepsis, but many approaches have failed in the past. One is adjuvant therapies such as monoclonal antibodies. The other was activated protein C, the use of steroids or other molecules such as inhibitory proteins. The only approach that has demonstrated some level of impact on sepsis is the extracorporeal removal of endotoxin and the extracorporeal blood purification with non-selective removal of endotoxin and inflammatory mediators. So the concept behind this is that we may have a sequential approach which starts with the control of the site of infection, source control, then endotoxin removal by specific extracorporeal blood purification, immunomodulation and cytokine removal, which is general and aspecific, and finally, achieving multiple organ support therapy through a specific organ support. We have tested the different approaches in terms of blood purification techniques, high volume hemofiltration, cascade hemofiltration, plasma exchange, coupled plasma filtration adsorption, chemoperfusion, and high cutoff membrane, and recently high absorption capacity membrane seems to be a promising approach. The reason for this is that the chemistry of absorption is different from the classic diffusion and convection mechanism, where you have interactions between solute and the sorbent bed or the sorbent surface, which includes ionic interaction, van der Waals forces, which are mainly weak, and finally hydrophobic interactions that are strong and really effective. The AN69 membrane is not a new membrane. It started very early in the history of dialysis, and it is a copolymer of acrylonitrile and ionic sulfonate group. It was the first commercially available synthetic membrane, and the membrane with, let's say, high flux. And with respect to complement activation, it was recognized as the clinical reference against other members should be compared because part of the complement was absorbed and together with activation products, and this led to a special biocompatibility in dialysis. ST, surface-treated membrane, was introduced for chronic hemodialysis in the year 2000 and for CRRT in 2005. And finally, the Osiris filter was introduced in 2009 and expanded indication in 2017 for condition of excessive endotoxin and inflammatory mediators level. Basically, from the AN69 membrane moving towards the surface-treated membrane, there is a branched polyethylenimine layer which neutralizes the negative surface charges responsible for a specific zeta potential of the membrane. And finally, the Osiris filter has a thick linear polyethylenimine layer to which heparin can be bound, improving significantly the biocompatibility. The Osiris filter set demonstrates high capacity to remove the circulating endotoxin, which is quite similar to the one of specific polymyxin B-based hemoperfusion, demonstrating that endotoxin can be actively absorbed on the surface of the Osiris membrane. Also, the Osiris filter set remove together with endotoxin significant amount of cytokines, and as you can see here, there is a specific profile that you can see in case of Osiris similar to sorbents that have been specifically designed to absorb cytokines such as cytosorb or the Jafron cartridges that recently appeared in the market. In particular, the endotoxin concentration decreased significantly when you do a randomized controlled double-blind study. This was done in 16 patients, showing a change in median endotoxin concentration over time and significantly different removal of endotoxin compared to standard surface-treated membrane. The same is true for TNF-alpha and for interleukin-6, demonstrating once again the high capacity of removal by absorption. I'd like to remind that TNF-alpha is a monomer, but often present in a trimeric form with a molecular weight that ranges up to 54,000 Daltons, and this cannot be removed by filtration. The change from vaseline to the end of treatment of different parameters, including interleukin-6, interleukin-10, and endotoxin, and additional studies on procalcitonin have demonstrated the significant capacity of removal achievable with the Osiris membrane. And in particular, this reflects on a biological signal, which is also a clinical signal, which is a significant reduction in the requirement of norepinephrine dose necessary to maintain adequate hemodynamic condition in the patient. So you see over 72 hours of treatment with Osiris, you have a specific reduction which is more than half of the concentration of norepinephrine dose required to maintain adequate hemodynamic response. And this reflects in different organ perfusion and organ status. In fact, improvement in SOFA score is observed already at T1. The value of application of Osiris in sepsis is well demonstrated by a randomized controlled trial where you see that basically there is an improvement in heart rate, respiratory rate, dose of noradrenaline, and also in case control condition, where 23 patients treated with Oxiris versus a control group of 30 patients demonstrated a reduction in the duration of ICU stay, the duration of organ support, especially mechanical ventilation, and the incidence of cardiovascular event. In this cohort, with 30 patients versus 46 patients treated with the standard membrane, there is a significant number of patients that have a characteristic of significant reduction of norepinephrine dose below 75% of baseline, and also display a special probability of survival. And this is a specific statistical analysis called inverse probability of treatment weighting method. Among the reasons to initiate Oxiris therapy, certainly sepsis is one of the primary reasons, and among this situation, hemodynamic parameters, level of inflammatory parameters, or presence of AKI and demonstration of gram-negative infection were the significant reasons to initiate Oxiris treatment. So our understanding of pathophysiology of sepsis and its treatment has evolved over the years, and while several membranes and different blood purification modalities are used for this, today the concept of absorption in general has expanded its potential application, both for solvent or for membranes that have absorption capacity, especially in the removal of inflammatory mediators that may suggest the use of extracorporeal therapies as adjunctive therapy. But we are not ready to create clinical trials using mortality as an endpoint because we're still struggling with the very first phase of sepsis, and the final outcome should be considered as a composite factor. In case of COVID-19, we were among the first to suggest the use of extracorporeal therapies in case of infection by coronavirus, and it was not possible to anticipate the extent of pandemic at the beginning, so the importance of organ support therapy had to be considered in light of the possible number of patients that may benefit from this. And at the beginning, we found that the COVID-19 was a sepsis-like syndrome that could occur both for superimposed bacterial infection or for the presence of a cytokine storm, and the presence of circulating mediators had to be considered as a target for therapy. In these conditions, extracorporeal organ support and removal of cytokines could present some specific benefits. In fact, in this publication that we placed in Lancet very early in the history of the COVID-19, we demonstrated that among the mechanisms, the cytokine storm and the immunodysregulation was one of the main mechanisms affecting endothelial dysfunction and possibly leading to organ failure, not only for the kidney, but also for the heart and the lungs. In particular, patients with COVID-19 displayed significant levels of the inflammatory mediators in the plasma, and this was clearly demonstrated mostly in the severe condition. So these are the patients that may require this kind of therapy, that even considering this as a sepsis-like syndrome, may start from the control of the infection and then subsequent mitigation of the immune response and possible removal of mediators of organ damage. Cytokine removal, in fact, could prevent cytokine release syndrome-induced organ damage, and we published this very early in Nature Review Nephrology in 2020 as a result also of a consensus conference that in which basically the removal of cytokines through the use of neutral macroporous sorbents or modified filters such as oxides could find the application, and some patients could directly benefit from this type of approach. The consensus conference had important questions such as what is the potential biological rationale for using no-renal indication of extracorporeal blood purification therapy in critically ill patients with COVID-19, and the response was a statement that inflammatory cytokines and damage-associated molecular patterns, together with pathogen-associated molecular patterns, including endotoxin and SARS-CoV-2 particles, potentially contribute to the development of multiple organ failure and mortality in patients with COVID-19. And extracorporeal blood purification techniques have been shown to remove cytokines, dumps and pumps, including endotoxin and circulating viral particles. So, what can be the right technique to remove circulating molecules implicated in the pathophysiology? Well, hemoperfusion with sorbent beds can certainly remove high amounts of inflammatory molecules because of the large surface area. Therapeutic plasma exchange can be one of the therapies, and certainly CRRT with surface modified AN69, such as the oxidase membrane or other members with high capacity of absorption, may represent important resource. To continue with the therapy, especially in patients with developed AKI, the idea of using medium cutoff membrane to remove target molecules seems to be an appropriate approach. So basically, in case of viral infection where pneumonia develops and it is aggravated by mechanical ventilation of extracorporeal membrane oxygenator, there is a specific release of cytokines that can be pro and anti-inflammatory disorder, and this can be partially blocked according to the peak concentration hypothesis, utilizing mechanisms such as hemoperfusion or CRRT with the absorption membranes that remove the peaks of pro or anti-inflammatory mediators, leading to endothelial protection and organ support. This is a demonstration of the capacity of oxides to remove significant amount of IL-6 and improving in parallel SOFA score in patients with COVID-19. And also, in this case, there is a demonstration of the significant changes from baseline to 72 hours of treatment of extracorporeal blood purification with oxides in terms of interleukin-6 variations, SOFA score, and also X-ray severity as demonstrated by the chest X-ray analysis. So what are the perspectives on blood purification for COVID-19? I think the oxidase filter set seems to be a promising therapy for two reasons. One, for the high absorption capacity. Second, for the kidney support and the capacity to provide adequate blood purification. In the early phases, other elements such as polymyxin B or Jafron or cytosorbents can be applied, but in the very early phase. Subsequently, it is probably more important to consider membranes that provide simultaneously absorption and also diffusion and convection for organ support. It's important to start quite early to provide frequent filter changes if absorption is one of the mechanisms that are advocated to work very well because of saturation occurring on the surface that absorb the target molecules. And certainly we will may benefit of citrate anticoagulation in several patients, but we still are waiting for further evidence, although small, very targeted studies have demonstrated that these treatments are capable of doing exactly what they claim to do. With this, I just thank you very much for your attention, And I hope that I was clear enough, at least on my vision on the extracorporeal blood purification therapy for sepsis and for COVID-19 patients.
Thank you very much, Claudio, for this excellent overview, historic overview, I would almost say. We have a couple of questions from the audience. One is more a generic one, I would say. I guess it refers to the fact that you are having a lot of educational programs in your institutions running. And the question is, how long does it take the training for a nurse or a doctor to master the usage of a CRT device?
Well, I think that the concept of training and education goes beyond the simple teaching of the technical issues, the connection, the use of the machine, etc. It is more about the philosophy of approach to the critically ill patient. And it is, for example, very important to recognize early the patient that may require renal replacement therapy, and possibly to recognize early those patients who have hemodynamic instability and may require what we call sequential extracorporeal therapy, starting from the endotoxin activity assay and moving towards cytokine measurement and then supporting the organ. It is clear that the earlier you start, probably the more you prevent severe conditions, and this is what we have seen. For example, if we apply this type of therapy in patients who are severely unstable, it's a common finding 6 hours later to see significant reduction in the need of noradrenaline, etc. So in general, my idea is a nurse can easily learn how to use the systems in a few days because of the technical aspect is not so complicated. And we do on purpose specific courses. Next year in June, we are going to repeat our international course on AKI and CRT. We also do courses for nurses with hands-on sessions for different machines, because traditionally in our center we always had all types of machines and treatment. But basically for doctors and nurses, combining a kind of nephrology rapid response team and critical care nephrology team in a hospital, which is ideally created by a nephrologist and intensivist, sometimes it takes 2-3 months at least to enter into the idea of moving together towards the critical ill patient rather than calling somebody for a consultation. So it depends very much, but we learned that it takes time to enter into the philosophy of the critical care nephrology approach.
Thank you. So the technical aspects should be learned easily nowadays or fast with the existing technology, but obviously there's more to it and that can take time, and obviously also to what degree and level of expertise somebody is willing to invest.
Yeah, we must recognize that the modern machines are certainly improved compared to the previous models, and they make the job of the nurses much easier and simpler. The downtime in particular is much reduced because of some aspects. For example, in the new Prismax, the possibility to eliminate the drain of the spent dialysate directly instead of changing the bags, etc., is certainly something that facilitates the work of the nurses, etc. But we also have the software that help to minimize the downtime, and this reflects in a better therapy for the patient.
Thank you. We have now more related to blood purification. When is the right time to consider initiating, and when could it be considered too late?
So this is a very interesting question because after almost 40 years that we have been working in the field of CRT, people are still debating when is the right time to begin the renal replacement therapy. Here we are in a different area, which is extracorporeal blood purification for sepsis and non-renal indications. So my answer can only be a philosophical answer rather than supported by randomized controlled trials that we will never be able to do it, by the way. And my point is that this therapy in this moment is considered not just a rescue therapy, but also a preventive therapy. If we are able to reduce the level of severity induced by immuno dysregulation, we can probably save a lot of organ failure. For this reason, my personal approach is to start as early as possible when the signs of hyperinflammation and altered hemodynamic response is present. Somebody may claim that we are doing this as a futile therapy, but today the level of complication due to this therapy are minimized and the impact on hemodynamics is evident. So personally, I would say that it makes a lot of sense to start quite early. Of course, when is it too late? Well, if you develop acute kidney injury and organ failure, it is too late to prevent. But it's not too late to treat the patient with organ support. So it depends on what the target is for your extracorporeal blood purification approach.
Thank you. Another study, I'm not sure whether we have time to fully answer that question, but how should we adjust for antibiotic dosing during blood purification?
Oh, this is a very interesting question. I must say that both sorbents and membranes with absorption capacity tend to absorb antibiotics. Plus, if you use membranes, antibiotics can be cleared because their molecular weight is very small, unless they are linked proteins. So not every antibiotic has the same kinetics. But certainly, we have to consider administrating antibiotics in a way that the concentrations in blood respect what the indications are. We have recently studied vancomycin, for example, and we have seen that both sorbents and sorbent membranes, let's say, absorb significant amount of antibiotics. So for sorbents, it's easier because you may apply them for 2, 4, 6 hours a day, and then you continue for CRRT. With CRRT, you apply this for 24 hours. So you have to be careful to compensate for the amount that you are losing in the dialysate and the amount absorbed onto the membrane.
The one other question was, how would you generally dose the dialysis prescription with Oxiris? Is there any difference to a regular dialysis prescription?
Again, it depends on what is the target of your therapy. If you use the Osiris as a membrane for CRRT, the dose should be the classic dose, which is never go below 20-25 milliliters per kilogram per hour, because this has been demonstrated to be an adequate dose. But of course, this has to be a dynamic prescription, because if the patient, in spite of that dose, seems to have azotemia climbing and symptoms, you may want to increase the dose up to 30 milliliters per kilogram per hour. And you have to compensate for downtime, and you have to make sure that you're not under dialyzing the patient. But if you are using the treatment to prevent organ damage and to absorb cytokines and endotoxin, the dose is more based on a biological response of the patient. And if you see a biological improvement with improvement in SOFA score, reduction of cytokine concentration, although the measurement of cytokine concentration is a tricky element, and I would more stay on the biological response, such as, for example, improvement in monocyte function, HLA-DR, or other monocyte function like phagocytosis, etc., or clinical response, which is reduction in noradrenaline and reduction in organ support intensity. At that point, you just titrate rather the dose, you titrate the duration of your therapy, which may be for a session of 12 hours every day up to 24 hours every day, considering, however, that the absorption component of the membrane saturates after a while. So you may need to change the filter more frequently if this is the target that you want to achieve. The same is true for combination of sorbents together with the membrane and so on. So it is very different if you're using this as a preventive therapy or as a rescue therapy or as a support therapy.
Thank you. Claudio, maybe last question. So when you treat a COVID patient with Oxiris, was there any, let's say, specificities that you encountered as compared to a normal sepsis patient? And I know we're talking about a very heterogeneous patient population, and also this depends obviously on the variants, but is there anything that you saw or realized that made it different?
Well, what makes it different is the environment where you're doing treatment, and nurses may need treatments that require minimum intervention in the therapy. So, for example, the use of citrate anticoagulation is almost mandatory, I think, to permit prolonged function of the membrane without intervention needing to flush the circuit, etc. And so this is one of the main aspects related to the COVID-19. Nurses are forced to work with the special protection measures, and it's really inducing a lot of fatigue, a lot of demanding work. So the technical aspects should be as simple as possible. While the septic patient, you can be at the bedside and change things, etc. The COVID-19 patient, especially the most severe, require a smooth therapy in which you tend to have all the technical aspects solved and working without too many interventions.
We, as industry, we also have received a lot of requests related to that, as you can imagine, like telemedicine and I don't want to say no-touch medicine, but something, that makes sense. With that, I would like to thank Professor Ronco very much for his time and his sharing his expertise with us. And we will move on to the next presentation, which is related to this. Maybe this would being having been a more general discussion on blood purification, but will now focus on the Qatar experience. And Dr. Mohammed Adel will, who is a consultant in the Critical Care Medicine Cooperation Center in Doha in Qatar, will share with us his experience and using the Oxiris filter in COVID patients. Dr. Adel, please.
Thank you, Kai. Really, I'm grateful for the kind invitation, and it's an honor to discuss this after Professor Ronco, which put a lot of a challenge. But I'm honored to present our experience during the COVID pandemic after Professor Ronco. Okay, so good afternoon, good morning, good evening for everybody, and thank you for your attendance, and really appreciate the allowing us to share our experience with you guys. Next. So basically, I have no actual or potential conflict of interest in relation to this presentation. So after Professor Ronco, it would be difficult to give a background or summarize what we have learned from Professor Ronco. Looking at the, as Professor Ronco mentioned earlier, the systemic inflammatory states for the severe sepsis and the septic shock, along with the COVID, especially the immunological disturbance and imbalance happens between the release of the cytokines, the pro-inflammatory and anti-inflammatory response of the host. That will lead to a multi-organ dysfunction at a state and a high risk of death as well. Next. So looking simply at the mechanism of having the imbalance between the pro-inflammatory and anti-inflammatory host response, specifically at the cytotoxic effect of the cytokines, and on the other hand, the numerous production of the inflammatory mediators that will suppress the immunity of the host and lead to a state of basically immune paralysis, which contribute and have a high influence on the mortality. Next. So just to give a background on how we basically look at the purification therapy, how it helps in achieving the homeostasis and the balance. So attenuation of this overwhelming excessive systemic response of the pro-inflammatory and anti-inflammatory basically leads to the trying to achieve the hemostasis, which could improve the outcome, as we learned from the previous presentation. Next. So looking at the oxyrus membrane capabilities and how the oxyrus membrane has a unique function of removing the unwanted cytotoxic effect of the cytokines, along with the endotoxin removal. And as we can see from the showed algorithm, the graphs, comparing the different membranes between oxyrus and different membranes, how it's effective in removing lowering the level of the endotoxins and the cytokines. It's basically can function. It can function, do them more than function. So basically, removing the cytokines and endotoxins, as well as still we can use it, as mentioned earlier when we discussed about the dosing, classical dosing thing, when it is only for CRRT. Next. So oxyrus and the COVID-19, so basically it was FDA approved in April 2020. And just to share with you guys, when we conducted our small trial on the COVID-19 patients, we were looking at that basically came earlier than that on March. And when we designed our study, it was even before we get the oxyrus gets the only the FDA under emergency FDA approval under emergency situation. So and as we all know, that it is the only filter set available to reduce the pro-inflammatory cytokine levels in the blood, including the use in continuous renal replacement therapy for confirmed COVID-19 cases admitted to the ICU with confirmed or intermittent respiratory failure. And I would emphasize on the respiratory failure. That was the point we really based our primary outcome on using the Oxiris in the COVID-19 patients with suspected cytokine storm. Next. So looking back at the available data at that time, and there was a few studies evaluated the efficacy of the extracorporeal blood purification therapy using the Oxiris specifically in the critically ill patients. So there was a significant decrease in the inflammatory markers and organ dysfunction scores with the use of Oxiris filter. The Oxiris filter device removes both cytokines and endotoxins through an ionic interaction with its membrane composition. From that point, it led us to design our trial and start using the Oxiris in severely ill or critically ill patients admitted to the ICU. Next. So just to give you, to share with you our experience, I have to explain the situation during the COVID-19 pandemic. So with the support of the stakeholders and the leaders in the critical care among our corporation as well. And there was like having a dedicated COVID-19 facility. So, and much expanding the capacity of the ICU. So we had segregated the critically ill patients in a major ICU. One hospital became an ICU basically, and it was only dedicated for COVID-19 patients. And that gave us an easy way to implement our pathway for referral for the extracorporeal purification therapy. Next. So we had a retrospective study looking at the efficacy and safety of the extracorporeal purification therapy using the Oxiris filter in the treatment of COVID-19 patients with a cytokine storm in the critical care unit. It's a multi-center single health system, including critically ill COVID-19 patients requiring continuous renal replacement therapy. The study period was from March 2020 to October 2020. The study was approved by our local IRB as well. Next. So our eligibility criteria to analyze and to assess the efficacy and the safety. So basically, we included the patients above 16 years old with the confirmed COVID-19 positive PCR, admitted to the ICU and requiring CRRT, with a suspected or confirmed cytokine storm, having the high-grade fever, the multi-organ dysfunction, along with the high levels of the released interleukin-6. Next. So our primary outcome was looking at the patients alive and ventilator-free in 30 days. And secondary outcomes were the ICU length of stay, hospital length of stay, and how the change in the SOFA score from admission in 24 hours to and 72 hours, how many days they are ventilator-free, and the changes in the PF ratio as well, looking at from 24 hours to 72 hours. Other outcomes included changes in inflammatory markers between that period, 24 and 72 hours. Next. So looking at our flow chart, so we assessed for the eligibility total of 66 cases with the eligibility criteria, and we had to exclude 8 patients because some of them they received another extracorporeal purification therapy using a different filter, or they had a duplicate. On the purification therapy and CRRT. So Out of these, 35 received the Oxyris membrane, and we compare to 23 who received only the CRRT. Next. So looking at the baseline characteristics on enrollment, so looking at the age, sex, race, and chronic illness, it's similar between the two groups, having the race, the chronic illnesses. So we tried. We had most of similar between the either the Oxyris group and the CRRT group. Next. So along with the receiving the extracorporeal purification therapy using the Oxyris, there was for sure the different therapeutics were at that time during the pandemic, especially it was the initial wave. So the use of corticosteroids and remdesivir was, as you noticed, is higher on the Oxyris group. Next. Looking at the patient characteristic at the treatment initiations, so the similar percentage of patients were on mechanical ventilator at the baseline in both groups, with a BF ratio almost similar in the severity degree on the ARDS, ranging between 150 to 100. So SOFA score was in a lower in the Oxyris group. So looking at the primary outcome, and as we mentioned, we were looking at the alive patients with a ventilator-free at 30 days. There was a 31% of patients in the Oxyris group were alive without mechanical ventilation at 30 days, compared to a 4% in the CRRT side. Because of the baseline imbalance in the SOFA score, we have adjusted for the baseline SOFA score, and the odds for being alive without mechanical ventilation was 6 times higher in the Oxyris group compared to regular CRRT. However, it wasn't statistically significant. Next. So secondary outcomes. As you can see, we were looking at the difference and changes in the SOFA score, the severity of the illness between the Oxyris group and the CRRT group at 24 hours from the initiation of the therapy and 72 hours from initiation of the therapy. So there was no difference in the other parameters, as you can see. Next. But there was a significant reduction in interleukin-6 over time among the Oxyris group of patients, significantly difference between the two groups in favor of the Oxyris group. Next, please. To summarize, so it was the only study to compare Oxyris to a regular CRRT. The study showed a trend toward improved outcomes with the use of Oxyris in critically ill COVID patients with ARDS. Interleukin-6 decrease at 24 and 72 hours in patients on Oxyris compared to the baseline at the treatment initiation, and that meets the similarity found in other studies. Next. So have a good insight looking at our limitation. It's only a retrospective design. Again, we have a small sample size. Because of the imbalance in the severity of illness, as we adjusted the SOFA score from the initiating the therapy, majority of patients were middle-aged, Asian and Middle Eastern men, so that limits the extrapolation to other patients group. Next. So to conclude, when compared to a standard CRRT, the use of Oxyris for extracorporeal blood purification in critically ill COVID-19 patients requiring CRRT was associated with a higher percentage of patients alive and days without a ventilator at 30 days from treatment initiation, but it didn't meet statistical significance. We require a larger scale randomized controlled trials to verify our findings. And with this, I conclude my presentation, and thank you for attending and listening. Back to you, Kay.
Thank you very much, Mohammed, and congratulations to the study. I mean, it really is a pity that the SOFA score wasn't the same in both groups, and however, I think it is these are still important findings and an important trend. So thank you very much for sharing that with us. We have a few questions from the audience. One is, how did COVID patients on ECMO respond to blood purification, and what was their anticoagulation?
So looking back at the ECMO patients who had an ECMO along with the CRRT using we used the Oxiris as a purification therapy, they did very well. And basically, the days on ECMO were significantly lower on the Oxiris side. Those who received the purification therapy, when compared to those who only received the CRRT, they had a shorter days on ECMO, and the cannulation was earlier.
Okay. And can you say something about anticoagulation? Was there also some citral anticoagulation or heparin only?
So, basically, it was heparin only, and with certain patients, when heparin was basically contraindicated, we had to do it heparin-free.
Okay. I mean, ECMO also, especially if the patients are on ECMO for a longer time, can induce cytokine release as well. Did you see any changes or differences of cytokine levels between patients on ECMO and not?
We encountered, as I remember, it was only one patient, and I believe this is what one of the dose duplicates, so we had to exclude that from our analysis.
Okay. Another question is, on average, how many Oxiris sets does one septic patient need, and when do we know when to stop? Which is a difficult question.
Again, as I wouldn't add after Prof. Ronco, but again, it differs. But what we noticed, actually, especially in the early initiation of the purification therapy using the Oxiris, we have encountered a lot of cases. The membrane gets clogged, and because of the heavy removal and well saturated, basically, especially those with the high numbers of interleukin 6 and full-blown cytokine store. So an average, a patient to deliver a therapy in 72 hours maximum, 2, maximum 3 filters.
2 to 3 sets, okay. And are there any criteria by which you were able to terminate the therapy?
So I still remember the patients, the pattern of patients. They were the bedside significant improvement was the PF ratio, which had really shown a very drastic response to the delivered the post the starting the Oxiris extra corporeal purification, and the shortest, I believe, was like 48 hours. We didn't even complete 72 hours.
And maybe just to add to this, because this question has come up several times now, and obviously it is an important one and very difficult to answer, but maybe there has been a publication some years ago, I think by now it's 3 years ago, a consensus paper from a European experience using the Oxiris filter, and there were at least some parameters identified by which that could help to determine when to initiate or to terminate the therapy. This was again a consensus paper applying a so-called modified Delphi methodology, and the PI was Peter Pickers from the Netherlands. So maybe that could help to clarify some of those questions. Another question was, well, first of all, nice presentation again. Which filter did you use in the control group? That is obviously an important question.
Basically, on the control group, we were delivering only CRRT. So the M150, the usual, our usual filter using on the CRRT. So the other on the CRRT group, we were using only the M150.
Which is important to know that this filter also has absorption capacities for cytokines.
True.
So it's still, it reduced or not maybe reduced cytokine absorption capacities, but still interesting to see that there was a difference.
A trend of improvement.
At least a trend, yeah. Last question here was, can I use Oxiris with ECMO not for renal replacement? So basically hemoperfusion and ECMO.
We have done it. So basically patients with COVID-19 or even patients with septic shock, not having an AKI, we have been using we had the experience using the Oxiris as a purification therapy, and we had patients who had decannulated and from the ECMO as early as less than 72 hours.
Okay. Last question from my side, Mohammed. I mean, the virus obviously has changed over the time, and you know, we saw initially probably higher need for renal replacement therapy as compared to now where we are. Did you see any changes or experienced any changes over the time now in COVID patient using Oxiris? Was there anything that you realized?
I would say what we have noticed that the need for the purification therapy on the second waves, the consecutive waves, had become less. So the cytokine storm was really significantly less. But on the other hand, the need for the CRRT per se, and for those patients who develop an AKI was huge.
Yeah, and we struggled with that, as Hani has alluded to very initially, because the initial data from China probably underrepresented the incidence, or underreported, I should say, the incidence of AKI and CRRT or RRT requiring AKI. We then found, I think the first reliable data were from ICNARC from the UK, where it was reported to be 3 times higher, the incidence, than the average ICU patients, which was a bit of a challenge for us to meet that demand, and obviously, especially when there was higher filter clotting because of the coagulopathies that come with the disease and so forth.
Mentioning that, I would just conclude to basically, without the support of the ICU and the nephrology service during the pandemic and the administration of the critical care, since we met this high demand, and we were thankfully we were able to meet this demand at a certain level, and I mean, to run a study during this was challenging. So our small research group did a great job during this as well, and I send them our regards. Thank you.
Thank you very much, Dr. Adel, for your presentation and sharing these insights with us. We are about to go on a break. Before we do that, I would just like to let you know that you will receive some questions, and I would kindly ask you to respond to those. One is related to your location, so where you are, and some are related to the therapies that we are discussing, and we would like to maybe share these findings with you afterwards. So before you go on a break, please fill in or respond to those questions, and we'd be happy to show the results afterwards. With that, I suggest that we have a little coffee break and come back at the hour at 5 p.m. Thank you very much. Again, good morning, good afternoon, good evening to everybody. Welcome to our second session on blood purification technologies. We're changing gears a little bit, and after Osiris and CRT, we're going to look at other therapies. But before we do that, we will present you with the results of the poll. I don't know, will somebody please display them? So the first question was, how often do you perform TPE in your hospital? And the majority says that less than 4 cases per month. There are some, 24% says less than 3 cases per year. And then there's 18% not doing any TPE in the hospital. Next question, please. Which device are you using for TPE? The vast majority, 85% or even more, were using Prismaflex as the preferred device for TPE. Next question. How well do you know ECOR therapies, extracorporeal CO2 removal, I should say, using Prismax? Again, the majority says, in this case, I'm not familiar with this therapy. Some or 1/3 understand the basic principles. Nobody has a full knowledge of the therapy, and 13% says to start a program they would start a program as soon as it is available. Next question, please. What is the percentage of CRT to IHD in your ICU? The majority would say 25% is CRRT. 18% use CRT in 25 to 50% of the cases, and 24% use CRT in 75 to 100% of the cases. Next slide, please. Which blood purification device have you tried before in your ICU? Osiris was used by 46%, cytosorbent 7%, 0% have tried PMX before, 26 have used more than one device, and 20% said they never used extracorporeal blood purification. Next slide, please. According to your experience, what is your feedback about extracorporeal blood purification? And 57% said, I'm a strong believer. 26% said, I would only start in a rescue therapy. 7% said, I don't use because the costs outweigh the benefits. And 7% say, I would never use it. Interesting. Next slide, please. So this is the shows where we have most of the participants coming from. So we have representatives from Saudi Arabia, the Emirates, Kuwait, Morocco, Turkey, but also other countries like Poland, like Croatia, Singapore, Taiwan, Belgium, Great Britain, Iraq, USA. So pretty much from everywhere, which is great. Obviously, the largest group of representatives come from UAE and Saudi Arabia and Turkey. All right, thank you very much. Again, it seems that at least for some of the therapies that we're going to discuss, like eCore and also TPE, the knowledge or the experience is somewhat limited. So maybe this is a good opportunity to learn more about those and discuss with the expert. Again, I would encourage everybody to really use the chat function. We will again try to ask and answer as many questions as possible. With that, I would like to introduce our next speaker, Dr. George Alvarez, who is an intensivist at the University of Calgary in Alberta, Canada. Dr. Alvarez is the current chair of the department's renal replacement committee and helped start the TPE program in his institution. He has been a member of the DCCM since April 2006 and has a large experience for TPE prescription. And he will talk about TPE prescription and clinical practice or indications. Sorry. Please, Dr. Alvarez.
Everybody can hear me okay? Good morning from Calgary, the base of the Rocky Mountains. It's my pleasure to share my experience in creating a TP program at our hospital, specifically the South Health Campus. And it was really interesting to see the number of international people that are on this talk. And I'm glad that I've set up my talk in a combination of people that have experience and don't have experience with TPE. Today, over the next 25 minutes, my hope is that we review some very basic TPE terms and principles for those that are not familiar with it. I will concentrate on neuromuscular and neuroimmunological disorders, which is what we've ended up specializing in. I think hematological and oncology deserve their own special talk. And then I'll go through some very basic prescriptions and even share with you our current order set that I'm happy to share at the end if people are required. I'm a big believer in looking at our past to inform our future. So these are some of the highlights in transfusion medicine that I always find very interesting. And anytime I give a talk to our ICU fellows about anything, I always like to have them couched in history. As you can see, in 1818, the first confirmed transfusion of blood, of whole blood, was given to a postpartum hemorrhage lady, and then subsequently followed by the first transfusion to treat hemophilia. In the early 1940s, our colleagues at Harvard, using cold ethanol fractionation, started to break down the components of blood, the plasma water versus the cellular components, and they found this very powerful oncotic protein called albumin. Subsequent refinement allowed us to have blood stored in both plastic and in glass cylinders. And then about 60 years ago, plasmapheresis was created, which is really the fractionation of water to the cell components. And then about 50 years ago, the actual apheresis, the separation of cellular components, began. Now, apheresis is a very complicated process that is beyond the scope of this talk. And as you can see, there are many apheresis techniques, and we're going to be concentrating on therapeutic plasma exchange. And for those of you that have experience in TPE, you know that it'll be either done centrifugally or using a semi-permeable membrane or a combination of the two. Centrifugal is easy to understand. You drive blood through a cylinder, and the blood components, according to the relative density, are separated from the plasma water, versus the technique of filtration, where you put it against a semi-permeable membrane. This is a picture in our institution of the two common methods. On the left is somebody that has chronic TTP that comes in for regular peripheral centrifugal plasma exchange versus what we use in our ICU, which is the more classic large bore into the neck in a continuous rather than an intermittent fashion. As noted in the voting, most people use TPE with their current CRT equipment, and this is a simple diagram of what it would look like. Now, the basis of TPE is really the removal of substances that are meant to be punitive or cause a disease. As you can imagine, they are dependent on many factors. An obvious one would be the size, its ability to move across the semi-permeable membrane. Another important consideration in your prescription is the volume of distribution. Is it within the intravascular space, which is the only space we have access to, or is it in the extravascular space, and there's egress between those two spaces? Obviously, how aggressive the disease is, the speed of the production or the replenishment of said punitive antigen is also important. I use this as an example. So despite IgM being 9 times larger than IgG in cytokines, IgM is mostly intravascular. So as you can see on that figure to the right, it's much easier to remove it from the intravascular space despite its size. Whereas IgG and cytokines have only 50% within the intravascular space. And that becomes important because when you try to figure out the prescription of TPA, if you're going to give it every day or every other day, you have to take that into consideration. There are many purported mechanisms of how TPE works. The first one is usually the easiest to understand. If you remove a punitive antibody that causes a disease, or as in the old days, removing the evil humors, that's an easy thing to understand. So whether it's the Miller-Fisher variant of Guillain-Barré or NMODS, or formerly Devex disease, where we take out the aquaporin 4 antibody, or perhaps more familiarly with myasthenia gravis, when you take away acetylcholine receptor antibodies or MuSK antibodies, that's an easy thing to understand. Some other interesting things that that are purported is that if you remove this antibody by TPE, it results in a negative feedback loop for the lymphocyte proliferation, thus allowing the ultimate definitive treatment, the immunosuppressive therapy, to work. Some other purported mechanisms are changing ratios for B and T cells, improving natural killer cells, and also improving T cell receptor. I think Dr. Ronco did a very nice job in discussing cytokine and sepsis, so I won't discuss that any further. So just to review, what you're trying to do in TPE is to remove something, whether it's an immune complex, antibodies, all of the above, or things that we still haven't discovered. And when you remove those things, you then have to replace the plasma. I use this when I give my CRT talk because it's a very nice view of all the different extracorporeal circuits that we have that have access to the plasma and some to the blood cells, is that you have to take into account what you're doing with what machine and what molecule you'll be able to remove it from. In renal replacement therapy, we are obviously mostly interested in the small molecules. The inflammatory molecules tend to be more medium to large, and what we're interested in TPE is more large molecules. And here's a very nice representation of those said molecules. So in TPE, we are concentrating on the immunoglobulins, which are at the top, which are extra large. And then obviously in renal replacement therapy, we are looking at these tiny little molecules, the urea and the creatinines, that have Sevine coefficients of 1 that will basically cross any semi-permeable membrane. One of the things when another option that you have to consider here when you are exchanging plasma volumes is how many plasma volumes you are going to exchange. Most programs have settled in and around the 1 to 1.5 plasma volume exchanges because, as you can see to the right, you have diminishing returns, and you have to take into account the space that you're removing it from and the replenishment, and more is not necessarily better in plasma exchange, and it'll be obvious when I show you my prescription towards the end of the process. So in totality, when you're looking at some disease process, whether it's hematological, oncological, or neurological, or sepsis, you have to understand what the disease state is, where within the blood compartment, or intravascular versus extravascular, your punitive thing that you're trying to remove from blood is at, how quickly it rebounds, and then the half-life. And if you don't understand this, it'll be very difficult for you to figure out a treatment schedule. So in a very, very simple cartoon here, you will see that plasma membrane filtration, what we're really doing is we're taking out the blood, we're filtering it out using convective loss, and we're dragging that antibody out. And so what we get filtered out is the proteins, the electrolytes, the immunoglobulins, which we're interested in. And what is not filtered is all the cells. So I think before I go to the second part of my talk, I think the key points here for those not familiar is that plasmapheresis really is trying to directly remove a pathogenic autoantibody and potentially other plasma factors to provide a temporary therapeutic benefit, whilst concomitantly you are giving the appropriate immunotherapy and other underlying treatments so that the condition can actually be treated. I can't tell you that TPE reverses a disease. It is a temporizing measure. However, it's taken me many years to get specialized in this at the South Health campus. So it is limited to large centers and requires a quite amount of specialization. And of course, there are certain diseases where TPE and, say, for example, IVIG have equivalency in it. So what are the top indications that we use here in Calgary in conjunction with our neurology colleagues? This is a small list of what probably has the most evidence behind, and certainly anecdotally, the greatest effect, whether it's an acute demyelinating process versus a chronic disease processes that have known antibodies associated with it. Versus neuroimmunological that also tend to have antibodies associated with it, whether it's an NMOSD disorder that's refractory to steroids, autoimmune or paraneoplastic encephalitides that are refractory to IVIG or steroids. And then we have also had a few patients that have multiple sclerosis that are refractory to treatment. And you can see also transverse myelitis. These have various degrees of evidence behind it, but when you take a look at the plasmapheresis guidelines, they are all aligned there as well. So what is our process? So practically speaking, so 3.5 years ago when we started to create this TP program, because our neurology colleagues want us to have one more tool in our armamentarium to treat their patients. It is a collaborative process where neurology decides on the indication. They get us involved, and we have chosen at the beginning of this program to do all TPE in the ICU. And the reason why we chose to do that is because once a nurse is trained in renal replacement therapy, in our case, we use the Prisma Flex and now the Prisma Max. The learning is very quick for them. It is only a couple of hours. TPE is quite a bit easier than renal replacement therapy. And then we come up with a schedule. And this is repetitive because it's on purpose. Antibody-associated diseases, we almost always go every other day because we know the rebound effect from the extravascular to the intravascular space. But a fulminant encephalitis, we tend to go on a daily basis. So what are the requirements for TPE? Some basic stuff. Well, first of all, you need some sort of extracorporeal circuit, and you need a large bore IV in the neck somewhere, along with all the requirements like the plasma filter set, the blood warmer. You need to determine what the prescription is, which I'm going to go through with you. And then you have to decide what type of anticoagulation and replacement fluid you will have. We have settled on using the PrismaFlex as our TPE. This was a near serendipitous interaction with a Baxter colleague of mine, where he comes regularly to do teaching. I do all the renal replacement teaching for our fellows, and I'm the co-chair of our department, including the TPE department now. And he literally said off the cuff, "You realize that our machine can do therapeutic plasma exchange. It's a small fee to enable the software program." And that's literally how our TP program started, realizing that this machine could do both renal replacement therapy and TPE. Him and I often joke about what would have happened if he didn't sort of casually mention that. The TPE set looks very similar to a renal replacement set. It's a cartridge that slaps right in the front of our PrismaFlex and Prisma machine. And again, much, much easier from a nursing perspective. You need to choose what filter you're going to use. You will notice the surface area is quite a bit smaller than the renal replacement therapy. And depending on how large your patient is, you have two choices on what type of filter you use. Now some basic stuff on actually prescribing it. And I'll spend a little bit more time here because it took a lot of time to make it look as simple as it does now. The first thing you need to do is you go back to med school and you calculate how much total blood volume you have. And we use the standard definition of 7 mils per kilogram times whatever weight the patient is. And for simplicity, I've given you the 70 kilogram gentleman that has about 5 liters of blood in their body. I will show you later on that when the ideal body weight is more than 20% of the actual body weight, we use a correction factor, which I will show you later on. From there, you got to figure out in that blood how much is cells and how much is water. What's the plasma? And that's why you need to have hematocrit. And that math is easy. If the hematocrit is 45%, then 55% of it must be water. So in this example, you can see that out of those 5 liters, about 3 liters of it is water. And then again, to remind you, you have to decide how many plasma exchanges you want to do based on the disease process, how fulminant it is versus non-fulminant. And most people fall between 1 and 1.5 plasma exchanges because of diminishing returns. So to use that as an example, if we were to choose on the higher end where we will do 150% of a plasma exchange, 3 liters times 1.5 is roughly 4,500. We have learned that albumin costs a lot of money, so we tend to round up to the nearest 250 mil to correspond with replacement fluid. For practical reasons, for nursing reasons, for pricing reasons, we have tapped out at about 5 liters of total plasma exchange per treatment. I will tell you that takes less than 2 hours to perform on a standard patient. You have to create an order set so that people can follow along. I know you guys can't read this, but I will be blowing it up in subsequent slides. I will tell you that this is probably iteration 17 or 18, and it took us a lot of time and error to figure this out. As you can see, when you blow it up, if somebody walks in the door in fulminant myasthenia gravis, they'll be getting the therapy within 2 hours of hitting the door in the ICU, or if they get admitted to the neurology department and they get given other treatment, then we can order on the floor and give it at a different time. And the reason why that's relevant is we have to talk to our blood bank colleagues to make sure that we have enough albumin. You can see on the right-hand side there are instructions on how to calculate plasma volume, all the things that I just reviewed. Further down, there are checkboxes on what type of replacement fluid we use. When we first started this, we chose 100% albumin, and as we've gained more experience and to save some money, we have now basically gone to a 70% albumin crystalloid split. A liter of crystalloid in Canada is about $1. We have learned through trial and error that the most important part of any extracorporeal treatment is to make sure that you complete said treatment. So we spend a lot of time hydrating the patient, anticoagulating the patient so we can actually deliver our treatment. In the rare case where the patient is also on renal replacement therapy and we use exclusively regional citrate anticoagulation, we have incorporated into this order set the ability to run citrate if necessary with nomograms on the back. And then at the back of the bottom page, you will see that there is reminders both to the nursing and the people to prescribing it on simple formulas and quick little notes. And at the very bottom, you can see that there is a correction of actual versus ideal body weight. So a little bit about anticoagulation, because that's very important. The whole goal of anticoagulation is to maintain the patency of an extracorporeal circuit. In renal replacement therapy, we use exclusively regional citrate anticoagulation, even if there's a concomitant indication for heparin, like a PE or DVT. I think the evidence is clear that regional citrate anticoagulation is superior to heparin in most extracorporeal circuits. And of course, we want to minimize the complications associated with anticoagulation. What we have fallen on is that we tend to use heparin most common. We thought we were going to use citrate more often, but because all the runs were way under 2 hours, it sort of didn't really make sense. And there's the occasional patient that we don't have to use anticoagulation for. So heparin, is certainly our first choice. Depending on the hematocrit, there's an option to bolus heparin like any other nomogram that will be in your hospital. We never have to do a PTT because all our runs are way under 6 hours. And then, of course, we don't use anticoagulation if there is a contraindication to it. Sometimes we remind ourselves that the receiving coefficient of heparin is 1, so it gets removed like many things with TPE. So we sometimes have to give a little bit more heparin as well. These are the problems that you tend to encounter with TPE, and there is some troubleshooting that you will learn. The only one that I would like to highlight is, the blood flow can go up to 400 mils. The slower the blood flow is, the more sluggish and the easier it is to clot. And on patients who are very dehydrated or that have a high hematocrit, we certainly tend to give them fluid. A replete patient is always a better run for any extracorporeal circuit, and we tend to give more heparin in those patients. Finally, to talk a little bit about replacement fluids. The whole point of a replacement fluid is you are replacing what you took away. So if you're going to remove all of this plasma that has the punitive autoantibodies, then we must replace that intravascular space with a concomitant oncotic pressure that you removed, and occasionally provide coagulation factors. The one that is most typically used in TPE is albumin. It is certainly much less expensive than fresh frozen plasma. To give you an idea, a 500 ml of 5% albumin is about $65 versus now up to $450 for fresh frozen plasma. As I've mentioned to you, as we've gained more experience and to save some money, we have now used crystalloid for the last 30% of our run. Fresh frozen plasma we use when there are specific indications, obviously things like TTP and HUS, again, is separate talk, or if somebody has a concomitant coagulopathy that actually needs fibrinogen or coagulation factors. But somebody who is slightly coagulopathic makes for a better run, so we only use this, the hematologists only use this when they're treating both acute and chronic TTP. A few clinical considerations regarding TTP. Obviously, there are some that are related to the CVC. Anytime you put in a large hose into a neck, you can certainly get infection and pneumothorax. And there are a few that are associated with TPE, which I think I rarely see. The most typical is hypotension. You're removing a lot of blood out of this patient's body and then giving it back in. Those are usually the adverse side effects, but I will have a slide to show you. Another important consideration is the type of medications that there are. Like ACE inhibitors for renal replacement therapy, there is a potential anaphylactoid reaction. And when you use albumin, it's slightly increased, so we tend to hold it for a day or two. We never diurese our patients. We always want them replete as much as possible. And TPE is very effective at removing drugs. And so we almost exclusively give things like antibiotics after TPE. And we have a pharmacist that rounds with us, and we have access to clinical pharmacologists as well. So those are some other considerations. To finish off, I wanted to share with you, our experience at the South Health campus. We celebrated our 100th patient last week when I was on service. We have done well over 550 runs. Obviously, during the pandemic, we've had to slow down, and we were only able to do, fulminant cases, whereas before we were able to give the, smoldering myasthenia gravis some treatment. Like everywhere else in the world, things had to slow down. I am in the process of completing a phase 1 study, a dose escalation study of TPE in septic shock patients. So I was obviously very interested to hear Dr. Ronco's talk. As he has eloquently stated, there's no single modulating drug or no real impressive trial in septic shock that has shown any real improved outcome, because I think trying to target one thing doesn't make sense. Whereas I think in TPE, we target everything, and and hence my interest in it. These are some of the complications that we've encountered in the last sort of 4 years of our TPE experience. Most can be fixed with simply reversing the lines, and the nurses do that all by themselves, just like when we won renal replacement therapy. Every cartridge costs about $450. And so having your filter clotted is bad and expensive and not good for the patient. Hence why I spent a fair amount of time talking about hydrating and anticoagulating your patient. And then these are some of the other problems that we've encountered as well. So that's a whirlwind tour of, my very exciting dive into the world of TPE and creating a program that is now certainly the largest in Canada for neuromuscular disorders. We'll be writing up our first 100 patients, and I'm happy to answer any questions and share any of my experiences.
Thank you very much, George. I think you really made an effort to simplify and kind of this was the most comprehensible presentation on TPE I've ever seen, and I really would like to thank you for that. So we have a couple of questions from the audience. One is, can we do double filtration on Prismaflex? Before you answer that one, maybe just one comment from my side, not on label, but maybe George has some experience there.
We've not done that. Like any other new skill, we've tried to get really good at it and not, push the boundaries. So when we got really good at TPE and our nurses love it, they're all CRT and Plasma certified. That allowed me to say, hey, can I now do a study on septic shock with using TPE? So I've not gone into the double filtration. I certainly can't tell you that there's any difference between centrifugal or Plasma, like there's no difference in the two. So that would not make any sense of doing them both to me, but I can't comment on that.
Thank you. Do you give steroids routinely for TPE? Patients receiving high volumes of FFPs?
No, I don't. I mean, if there's an indication for steroids for some other reason and we need to stress them, we do. But I do not give steroids to prevent, presumably what the person is asking, an inflammatory reaction by giving somebody else's blood products. We don't. You could see in our order set that there was, I'll bring up the order set here for you guys. Again, there was a part in there where you can give things like Gravol and steroid, it's been exceedingly, I've had not to use it at all. So the answer to that is no, we don't give it at all. But steroids are given concomitantly to suppress the immune system for whatever disease process we are giving. So remember, TPE does not reverse the underlying process. You still need to shut down the process. TPE buys you time for the immunosuppression to work. Yeah.
Thank you. How do you prevent hypocalcemia in TPE?
You know what? We routinely do blood work. We used to routinely do blood work, specifically for electrolytes. And because we don't use citrate very often, that becomes an exceedingly unlikely event. And if you don't use blood products that have citrate in it, then it isn't really an issue. So we were following that, and we had a couple of patients that we discovered that had hypocalcemia, and interestingly, they had another disorder that was related to like hyperparathyroidism that we discovered. But TPE, in our experience, doesn't cause a lot of significant electrolyte abnormalities.
Another one that's interesting. Have you tried Plasma-Lyte as a replacement solution with albumin?
Yes. Yes, I work with some anesthetists. There's a lot of discussion about using, of course, balanced solutions in septic shock and, renal outcomes and how people feel post-operatively if they're nauseous or not. So there's definitely contingent in my department that love Plasma-Lyte and hate normal saline. In my order set, which, I'm happy to share, you will see that the replacement fluid has albumin, fresh frozen plasma, and any of the standard 1 liter bags that include Plasma-Lyte.
And how do you calculate the ratio between albumin and Plasma-Lyte?
That was with the help of my hematological colleagues. When they do TTP, in fulminant TTP, they tend to give all FFP, but that's a scarce resource. Blood products are a scarce human resource. So with their help, we have decided that we use 30% as a ratio, because remember, when you're doing plasma filtration, you're taking away all of that oncotic pressure, and that ended up being expert opinion through people across Canada and the States that they chose 70-30. So it's not based on any scientific data.
Thank you. What is the parameter that is important in determining the duration of plasmapheresis?
Yeah, that's an excellent question. So when you take a look at the plasmapheresis guidelines, the ones that just came out a couple of years ago, based on moderate amount of evidence, they say 5 to 7 runs of dialysis, of TPE, whether it's daily or every other day, depending on the disease process. So in our institution, everybody gets 5 runs of TPE while we monitor them clinically in consultation with our neurology colleagues. Some of them stay in the ICU, some of them get their TPE, leave, and they come right back, 48 hours later. It is a clinical decision after 5 if they're responding or not. We've had a couple of very bad perineoplastic encephalitides in young people where we've ran them 15 times. So we've given them 3 rounds of 5. And that's just because they were young and they weren't getting better. So it's always about, are they responding to this treatment? So the minimum is 5, and very few people will go beyond that. And again, in this case series, I will be showing, the low and the high end. But yeah, we've ran people up to 15 times.
Maybe one last question here. Post-kidney transplant rejection, who's undergoing TPE is more prone to clot. What is the reason?
Yeah, I don't know the reason. If you do, I'd love you to tell me. I certainly have not used TPE for rejection. I know there is some interest in that. All of these people are already on immunomodulating agents like MMF and tacrolimus that already suppress B and T cells and natural killer cells. So they're already on a drug that does that for them. And that's one of the purported mechanisms that TPE might work, is by changing those ratios and suppressing those things. So I don't know the answer to that. That's an interesting question.
All right, well, thank you so much. It seems your talk has triggered a lot of questions, and some of them, I would say, it seems like there's a lot of interest and also expertise or experience there already existing.
Yeah.
So maybe that's another topic for us to continue to discuss in the future. Thank you again very much, Dr. Alvarez. And we will continue with our next presentation that is on the medical rationale for ECOR. Next slide, please. So before we get started, I would like to say that this isn't really a new therapy. This is a publication from Luciano Gattinoni from 1978, as you can see. And already at that time, he was thinking of comparing the technologies of renal hemodialysis to extracorporeal CO2 removal and extracorporeal oxygenation. And as you can see, probably the CO2 removal is more closely linked to hemodialysis as to ECMO, since the extracorporeal blood flow rates appear to be somewhat similar. Please note that at that time, the vascular access for renal replacement therapy was an IV shunt or an AV fistula, very similar to CO2 removal, and VV pumping wasn't really the standard of care at the time. Still, the surgical complexity was much lower for both hemodialysis and CO2 removal as compared, obviously, to ECMO. Next slide, please. This is a more modern picture of what ECMO and ECOR really do. Obviously, for ECMO, there are technologies that address both cardiac failure, respiratory failure, but also cardiorespiratory failure. For ECOR, we know there are veno-venous systems, but there's also pumpless systems that use an arteriovenous access. Obviously, the main condition that is going to be addressed here is CO2 retention, and the application is lung protection. So, next slide, please. Where is it that CO2 is retained? Obviously, what really comes to your mind is chronic obstructive pulmonary disease and its exacerbation. And potential indications for ECOR in these kind of patients could be either to avoid intubation in case of NIF failure, or to allow for rapid weaning from mechanical ventilation. Next slide, please. This is a study that was looking at about 40 patients that were at risk of NIF failure. And NIF failure was in this case defined as an arterial pH below 7.3 with a PCO2 above 20% of baseline and a respiratory rate above 30 and or the use of accessory muscles or paradoxical abdominal movements. Now, these patients either received ECOR therapies or were, next slide please, compared to an historical control. And what you can, a matched historical control. And what you can see here is that the incidence of those patients receiving NIF plus ECOR had a lower incidence of intubation as compared to the group that received NIF only. Next slide. There was also a reduction of mortality, but because of the low patient numbers, I would not overinterpret these findings. Next slide, please. A more recent publication, a small RCT, and in this case, we're looking at around 20 patients, was published recently. And here again, patients were randomized either to receive NIF only or NIF in combination to ECOR. And the primary endpoint of this study was the duration of NIF. And patients, as you can see, that received NIF and the combination of ECOR had a much slower, shorter duration, 7.5, 15 hours, as compared to the patients that only received NIF. Next slide. Also, there was a significant increase of the pH after 44 hours and a significant reduction of the PCO2 for the patients that received ECOR. Obviously, since after 7 hours, ECOR was terminated, NIF was terminated in the ECOR group, the parameters became somewhat similar again. Next slide. So it seems like there is some rationale for patients with COPD and CO2 retention. There's other studies ongoing also in the US and in other parts of the world. But what about other indications? Patients with respiratory failure or ARDS. And in this paper from 2019, Dan Brody summarized, if you will, the objectives, which is really to minimize lung stress and strain for patients with respiratory failure by reducing tidal volume, plateau pressure, respiratory rate, and driving pressure, and thereby decrease ventilator-induced lung injury, or VILI, which is described as volotrauma, atelic trauma, biotrauma, and barotrauma. Next slide, please. I'm sure you are very familiar with this concept of VILI that was very nicely described by Art Slutsky in 2013. Under ventilation or low ventilation can lead to atelic trauma, while high volume ventilation can lead to hyperdistension and air leaks. This is causing structural changes or consequences in the alveoli. Next slide, please. Which eventually can lead to biological alterations and systemic effects by the release of inflammatory mediators and others that eventually can lead to multi-organ failure or dysfunction and death. Next slide, please. This is really the landmark study that I'm sure many of you are familiar with, the so-called ARTSNet study, where a large randomized controlled trial was comparing patients receiving a lower tidal volume with patients receiving higher tidal volume. In average, the low tidal volume was around 6 ml, the high tidal volume was around 12 ml per kg. And you can see that that the death, that clinical outcome was significantly improved for the group of patients that received lower tidal volume, not only mortality, but also breathing without assistance, ventilator-free days, and days without failure of non-pulmonary organs was significantly improved. Next slide, please. But maybe there's even a rationale to reduce tidal volumes even further. I think nowadays a tidal volume of 12 isn't really standard of care anymore. Maybe there is a rationale to reduce tidal volumes even beyond 6 ml per kg. Next slide, please. Besides, so coming back to tidal volume, this is the so-called LungSafe study. In principle, it was a snapshot analysis of ventilation practices in ARDS patients. And they also looked obviously at tidal volumes. And as you can see, only 20% really received a tidal volume of 6 ml per kg. Next slide. Besides tidal volumes, could there be other indicators or parameters that are associated with mortality? And it was mentioned before, driving pressure could be one of those. This is a pooled analysis of several randomized controlled studies by Amato that was looking at the association of driving pressure and mortality in more than 3,000 patients. And as you can see, at a driving pressure of probably something around 14, there seems to be a significant reduction in mortality. Next slide, please. These findings again were confirmed in the LungSafe study, where patients receiving a driving pressure below 14 had a reduced or a higher survival in this case as compared to patients with a higher driving pressure. Next slide, please. However, and I apologize, these are really small number. I wasn't aware how small they are going to appear here. But if you look at the PEEP and the plateau pressure here, and you subtract this, you can see this is all ARDS patients on the column on the left-hand side. You can see that driving pressure in as a median was above 15. So even there, driving pressure was not below 14. Next slide, please. And the question is really why? And could it be that obviously concerns about acidosis and hypercapnia really inhibit at times physicians and nurses to really implement lung protective ventilation? What you see here are the results of a mathematical model where the baseline parameters of LungSafe were taken. As I mentioned, the tidal mean or median tidal volume was 7.6. And you can see then the PCO2, pH, and so forth that were associated and reported in that study as well. And then the tidal volumes were basically stepwise reduced. And you can see that even already with a tidal volume of 6, you're probably unlikely to achieve a normal PCO2 level and a normal pH. And this is even getting, is increasing, obviously, the more you are reducing the tidal volume. So in order to reduce the invasiveness of ventilation, certainly when it comes to what is called ultra-protective ventilation, CO2 removal may be a requirement. Next slide, please. So we oftentimes also heard the question, like we did today for other blood purification technologies, are there any criteria that I can use to initiate my therapy? Are there any treatment targets that I should look for? And are there also any criteria that I can use to terminate my treatment? And likewise, to the consensus paper that I mentioned in 2020, there was a meeting of experts for ECOR therapies. And the lead investigator in this case was Alan Combe from France. And again, by applying a modified Delphi methodology, criteria were defined and mentioned for initiation, treatment targets, and next slide, weaning. Obviously, as mentioned, driving pressure and P-plat being one of the most important criteria, pH and PCO2 as well. Next slide. So when we've launched the first Prisma Lung device some time ago, we obviously were trying to understand what is the efficacy of the device, what is the safety of the device, and whether it can serve the purpose, basically as a proof of concept. And this study was conducted by Schmidt in France. And basically, they started at baseline with applying a tidal volume of 6, and then gradually reduced the tidal volumes to 4, to 4.5, and to 3. And while you can see that at higher tidal volumes, PCO2 and pH remain somewhat normal, at lower tidal volumes, PCO2 and pH certainly were out of range, indicating that the device may not be efficacious enough or effective enough to remove enough CO2 to allow for normal parameters and the reduction of invasiveness at the same time. Next slide, please. So we decided to develop a new device. And here you see a study that was an in vitro study that was published using the new device now called Prisma Lung Plus, comparing it to the older device, the Prisma Lung, and another device that has similar surface areas or even higher surface areas, and also higher blood volume. Next slide, please. And again, this was an in vitro setting. Bovine blood was infused, if you will, with certain CO2 levels at 45, 60, and 80 millimeters of mercury. At the same time, you can see there were different blood flow rates, 200, 350, 300, and 400 were applied. Temperature was normalized to 37 degrees. And on the left side, you can see the CO2 removal rate. The CO2 removal rate for the Prisma Lung Plus device is always the right bar. The CO2 removal rate for the old Prisma Lung is on the left, and the other device was in the middle. And as you can see, although the surface area for Prisma Lung was smaller as to the other device, CO2 removal rates were at least similar or even higher, and certainly higher to the old Prisma Lung, indicating a higher efficacy. Next slide, please. Now, what are other studies? This is the so-called supernova study, and a study with enrolling around 100 patients and using 3 devices. One that is operating also at what we call the low flow space, so it's around 400 to 500 ml, and 2 other devices with medium or high flow capability going up to 1 or 2 liters. And as you can see, again here, maybe you can enlarge the picture a little bit. Thank you. For tidal volumes, there was a significant reduction. There was also a significant reduction in respiratory rate, plateau pressure, pH increase, and so forth. So basically, it was concluded that devices were effective in removing CO2 and establishing lung protective ventilation. Next slide. However, there were substantial numbers of complications, and it seems mainly related to the low flow device that uses a very specific technology. It has an integrated centrifugal pump in the filter, which may lead to either clotting or hemolysis. Next slide, please. And with this very same device, another large RCT was conducted, the so-called REST study, and this device was used exclusively in this study. This was, as I mentioned, a randomized controlled trial looking at patients with respiratory failure to either receive ecotherapy with the low flow device or standard mechanical ventilation. Next slide, please. However, and this was the study was terminated prematurely because of futility. In an interim analysis, the mortality rates were not shown to be different. Next slide, please. And I think when you look at these parameters, it becomes somewhat clear why that is, because really tidal volumes and driving pressure, and thereby the invasiveness of the ventilation, did not really differ between the group that received the ECOR treatment and the ventilation alone. So not being able to establish lung protective ventilation obviously cannot help to improve clinical outcome. Next slide, please. And again, there was a substantial numbers of adverse events that have been reported, which probably also caused for downtime and not allowed for a consistent application of the therapy. So does that mean the end of ECOR? We believe no. We believe at the moment the evidence is suggesting that the technologies that are existing have not allowed, in the past at least, for a consistent and effective delivery of the therapy, again, that really allows for a reduction of a significant reduction of the invasiveness of the therapy. In addition, there might be also other technology hurdles that need to be overcome. This device that I mentioned also uses a wire-enforced catheter, or comes with a wire-enforced catheter that also may lead or explain some other complications such as bleeding. Next slide, please. We are confident that our device that really is operating more in the setting of the renal replacement therapy, also when it comes to the catheter size, does not have these complication rates. The increased effectiveness make us hopeful and optimistic when it comes to the efficacy of the treatment. However, obviously, clinical evidence is needed, and we are currently conducting a post-market study, follow-up study for this device in France. With that, I thank you very much for your attention. I would suggest that we, in this case, maybe combine the questions that you may have to the end of the next presentation, because we now have Eddie Fan, who is a global expert on extracorporeal lung support, and he will talk about ECOR and the index registry. Again, Eddie is an associated professor at the Interdepartmental Division of Critical Care in the Faculty of Medicine in Toronto, Canada. And I look forward to his presentation. Thank you very much, Eddie.
So thank you, Kai, for the invitation to speak at this symposium. And I think my talk will follow very nicely from the superb overview you gave of eCore, where we were and where we're going with it. So I'm going to talk about eCore and the index registry and how infrastructure could help us to answer in a more expedient way some of the questions that we have that Kai brought up in his presentation. Who should we put the therapy in? When should it be deployed? When should we stop? What is the safety profile? We feel that registries could be very helpful in this situation. Here are my disclosures. I'm not going to speak about any specific devices. So I think many of you on this symposium may already be familiar with the idea of real-world data that exists in either disease-specific or device-specific registries. Clearly today, we're focused perhaps more on the device-specific nature of registries. And perhaps in the extracorporeal support space, the most prominent of these is the ECMO registry that's been in existence for over 20 years, centered in Ann Arbor, Michigan, with the Extracorporeal Life Support Organization, or ELSO. And when the ELSO registry came about, it was the first of its kind. It's the largest global voluntary registry of extracorporeal support that exists today. Here's just a snapshot of a recent report showing sort of over 100,000 runs having been entered into the registry to date, and it continues to churn along at a very important pace. But if you ask Bob Bartlett, one of the fathers of ECMO, and certainly the father of one of the most important founders of the ELSO organization, the registry came into being to understand how extracorporeal support was being used. So the intent was to get an understanding of the epidemiology at the 30,000 foot level, who is going on, what kinds of patients, what kinds of indications. Here you see, again, an example at a crude level of classifying those indications as pulmonary versus cardiac versus ECPR, to gain some idea of the safety profile, what kind of complications are occurring during ECMO runs, what are some of the outcomes like death, discharge from hospital, these sorts of things, and really to provide, with that level of understanding, a way to benchmark yourself against other ECMO centers. So as ECMO was an emerging technology at the time that ELSO was being formed, and it was diffusing across the world. So I'm starting to put ECMO in certain patients. Here's my complication rate. Here's my survival rate. How am I doing compared to some other centers that perhaps have been in operation for much longer than me, in hospitals that are a similar size as me, with a similar case complexity, and that sort of thing. So really to provide that kind of benchmarking and perhaps quality assurance as ECMO programs were being started, and certainly as they continued to grow in many parts of the world. And so if you ask Bob, one of the important things was that the initial idea behind the ELSO registry was not to help facilitate research. Because we wanted to get this 30,000 foot view and to get as many centers as possible entering data into the registry, the idea for the ELSO registry was to go broad and relatively shallow, okay? We wanted centers to facilitate centers in participating. You want to have them collect only what was necessary to reduce the burden. And this could hopefully help to have as many centers as possible be included. And so the amount of data that's in the ELSO registry is relatively concise, and it really doesn't resemble what we might need if we're conducting a clinical trial or doing clinical research, where you might imagine you'd want a lot of data over a good number of time from a longitudinal basis. In that idea, you would have a registry that would go deep, but probably in a much smaller number of centers that could facilitate that amount of data collection. And I think the importance of having these device-specific registries has been sort of elucidated in the popular press as well, particularly because safety or post-marketing surveillance has been a very important component or aspect of having these sorts of device-specific registries. Here's just an example from the New York Times a few years ago, suggesting that 80,000 deaths, 2 million injuries, it's time for a reckoning on medical devices. And just the idea that we need to better understand, like many interventions, whether it's drugs, it's devices, or even investigational or diagnostic strategies, that often what happens after they reach market is that they start to diffuse. There's a bit of indication creep. Patients who weren't necessarily getting them in controlled clinical trials start to receive that therapy or that intervention. And we need to better understand how these things are operating in the real world. And so this opinion piece sort of proposed that we needed tighter approval standards, we need a way to fix post-market surveillance, and perhaps an important thing was to increase everyone's confidence on how these things were being monitored, perhaps to loosen industry's grip. So it's sort of interesting that it was a double-edged sword where regulators like the FDA or European Medicines Agency would require companies to create these sorts of registries to understand what the post-marketing surveillance was. There was always perhaps a bit of skepticism, healthy skepticism, in terms of if industry, the people who are marketing these devices are creating these registries, could there be a bit of a more arm's length procedure which might increase the confidence in the results that come from those registries? And so the idea, of course, is that this performs a very important regulatory or safety aspect. And perhaps a good example of this are device-specific registries that have looked at TAVR, or transcatheter aortic valve replacement interventions in patients. Again, a very expensive device, which is increasingly being used in patients all over the world. And the idea here is that after an intervention like TAVR comes into the market, understanding the real world utilization, the real world safety profile, and the real world indications or patients where it seems to be having a good benefit versus those where it seems to be causing an excess of risk, you can tweak then, or better refine what the appropriate indications could be, proper patient selection for those sorts of things. And I think even regulators now are understanding that having these sorts of high quality registries, device-specific registries, are important, because having a new clinical trial designed and waiting years for results, if you refine these sorts of criteria every time that's required, would sort of defeat the ability to provide what could be a life-saving and important intervention in many patients. And so having these sorts of real-world repositories or real-world data would be very important to help clinicians, regulators, and researchers better understand where helpful interventions could be applied more safely. In the middle, you also see the idea that you also can have the opposite effect, where there are examples, and this was related to a vascular closure device that reached the market in the United States with the idea of a very close post-marketing surveillance. And over time, in patients who had the vascular closure device deployed, they actually found an excess of risk as it was being applied in real-world settings around the United States. And that actually led to regulatory action where that device was removed from market. So can provide both a refinement of the patient indications or selection for these devices as time moves forward and use expands, but can also certainly help flag important safety signals where regulators might need to act and better understand where to remove the device. But I think one of the things that's been very important, and we'll speak in the context of COVID, which may be part of the silver lining of COVID, is the idea that registries in them themselves, other than fulfilling a post-marketing surveillance, a safety, regulatory aim, and as well as understanding, again, the benchmarking or quality assurance that we talked about for the ELSO registry, they can also provide very important infrastructure to help us as clinicians and researchers to understand whether a therapy works, in whom, when, and how. And although we always think of randomized controlled trials and clinical trials as the gold standard of establishing the efficacy of these interventions, sometimes they can't always address their needs. And certainly in the extracorporeal device space, it's very challenging and very resource intensive to conduct clinical trials of this nature. Sometimes we need more timely determination of safety and effectiveness in real world settings, and registries can help us to do that. And certainly in many regulators around the world, there's been this increasing interest in the role of observational data or real world data to help inform regulatory action and licensing of devices, as well as to understand in whom these interventions or devices could be helpful in. And of course, we've already talked about some of the other important functions that registries could weigh in on, including continuous quality improvement, benchmarking, large-scale epidemiology, and the like. So this is a nice opinion piece that sort of summarized this sort of changing paradigm, at least in North America, with the FDA, who's really considering, with the 21st Century Cures legislation, a way to speed up and sort of in developing guidance around some of these things, and certainly in drugs and devices for patients, and increasing the use of real-world evidence. And they're really starting to think that the prominent inclusion of such data from real-world data repositories, like a registry, could be a possible determinant of approval. They're going to start to rely more heavily on these data rather than objective clinical outcomes measured in randomized controlled trials, understanding the real challenges of conducting these trials, particularly in the device space. Here's an example, again, despite the fact that Dr. Bartlett might say that the ELSO registry was never designed at the outset for research, a lot of research, very important research, has occurred in the extracorporeal arena using data from the ELSA registry. Here's a great example of how Ryan Barbaro, who's an intensivist at the University of Michigan and who was the chair of the ELSA registry up until the end of this year, who designed an additional module of data collection around COVID-19. When the pandemic hit and very alarming reports of very high mortality were coming out about the use of ECMO in COVID-19 patients, particularly in China and in Wuhan, there was a call for a moratorium on ECMO use in these patients because people were worried that perhaps the interaction of ECMO and COVID-19 was different than we would expect for ECMO and ARDS of other causes. So Ryan designed this addendum with his colleagues at ELSO, and data was collected. Here's the results from the first 1,000 ECMO runs on COVID patients in centers around the world. And importantly, if you focus on the graph on the right, what you could see is that the cumulative mortality was in the 35% range. And when you compared that with the historical mortality from ECMO use in the registry for ARDS of non-COVID causes, it was essentially the same, suggesting that when centers were using ECMO for evidence-based indications as they had reported to the registry before COVID, if you deployed in COVID, you actually had results that were quite similar, sort of rebuffing some of these early single center or case reports suggesting very high mortality in certain patients with COVID-19. I think the other thing that we could look at is that we could take it a step further. We now, many people, including Miguel Hernan, who's a biostatistician from Harvard, who published a number of papers using this technology. We now have a very advanced causal inference techniques that we could apply to observational data to basically emulate or simulate what a clinical trial could look like, especially in situations where you can't readily conduct a randomized control trial. This is a technique called target trial emulation. And Dr. Hernan has used this method to publish a number of articles, particularly in the New England Journal, comparing interventions that normally couldn't go head-to-head in an RCT. One example in this issue of the New England Journal, even though he published this opinion piece, was how he used health records and data from Israel, where he could emulate a randomized control trial of Pfizer COVID vaccination versus Moderna COVID vaccination. So that we weren't going to get a head-to-head trial comparing these two different vaccination strategies, but using millions of patients who received the different vaccines in Israel, he was able to emulate a clinical trial to show that essentially they were pretty similar. And that result was published in the New England Journal. We could bring to bear similar kinds of techniques using data from a device-specific registry like the ELSA registry and like Index, which I'm going to describe to you, to hopefully answer some of these important questions while we're waiting to design randomized control trials or clinical trials to prove that. And just as a proof of concept, we actually did this exact analysis in the setting of COVID-19 because, again, of all this concern and uncertainty about what the potential effectiveness of ECMO therapy would be in patients with severe COVID-19. So one of my graduate students and colleagues, Martin Erner, here in Toronto, used the data from John Fraser's COVID-19 Critical Care Consortium. So this collected ECMO use in COVID patients from around the world. And we simulated a randomized control trial of ECMO versus no ECMO in patients with COVID-19 from this data source. And what we found was, if you just focus on the top left here, was that the absolute risk difference between getting ECMO versus not was about 7%. So a 7% reduction in mortality in patients who received ECMO as compared to those who didn't. And when you think about the Eolia trial that showed an 11% risk difference in favor of ECMO, this is a very similar and consistent result. So increasing our confidence that this sort of methodology used in COVID patients resulted in a very similar magnitude and direction of effect for ECMO therapy. And our results were very robust in a number of sensitivity analyses and other control analyses to, again, increase our confidence that even though this isn't a clinical trial, that it really very much emulated what a clinical trial would have shown if it was conducted in COVID-19. And the reason we need these real-world data, these registries, and these techniques is because it's very difficult to conduct clinical trials in this space. This is a nice opinion piece from Luciano Gannoni and Michael Quintel showing exactly that. The CSER trial, which was our first trial of VV ECMO in adults, took nearly 9 years to complete, enrolling 0.03 patients per unit per month. Eolia took nearly 6 years and enrolled slightly faster, but that was still a very long time. And even though they're clinical trials, they're still subject to bias and secular trends. A good example is Eolia. We were a study site for Eolia. In the middle of Eolia, we had to change the protocol and the control group strategy because ProSiva had been published, and now prone positioning was a new standard of care. So as trials take longer and longer to conduct, you might actually have to change the way that you do things. And certainly the control group or usual care arm could also change over time, which could have a significant influence on the results. And if we needed to confirm this 11% absolute risk reduction in Eolia, it would take over 600 patients. And at these historical rates, even with 100 units, it would take nearly a decade to complete. So we need other more efficient and resource friendly ways to answer these important questions, many of which Kai brought up in his presentation. And we think that registries are a good way to do this. Of course, the other problem is the costs. And even companies like Baxter, who are trying to understand how to bring these important products to market, as costs for pivotal trials approach $100 million in some cases, we're going to find it vanishingly challenging to conduct these trials to bring novel therapeutics to market for our patients who are critically ill. I love this slide that was shared with me by Carol Hodgson, one of my colleagues in Monash in Melbourne, but that Renato Bolomo, who's a very accomplished and famous clinical trialist in critical care, told us that that's an important consideration. The resource limitations and the resource challenges of conducting trials in this situation are very difficult, because there's only two questions you need to answer when you're planning a trial. Do I have the money, or do I have the patients? And of the two, money is the most important, because if you have the money, people will get you the patients. So again, finding ways to make clinical trials more efficient and more time effective is going to be important for all of us. And we think that embedding trials, and we've learned this from COVID, it's been very successful, both in the recovery sense in the UK and certainly in the REMAP CAP setting in many centers around the world, that embedding research into registries, attaching those to adaptive platform trials could be one way to make these results faster and more efficient for their conduct. And that led us in part to the creation of this international research database for extracorporeal support. This is a project that I'm leading with Dan Brody from New York and Carol Hodgson from Melbourne. And again, this was the idea to make something that was complementary to the ELSO registry. So what the ELSO registry's main concern was to go, again, pretty shallow and broad. Our idea was to go deep but narrow in centers that were interested in collecting very granular data to help support research, which wouldn't be every center in the world, but certainly some high volume and interested centers in many places around the world. So the idea behind Index is that it's a relatively granular longitudinal database that's built in REDCap. And importantly, it includes all the data fields that are in the ELSO registry. So for centers that are already submitting data to ELSO, you wouldn't have to collect the data again. It's already all embedded into Index. So it's extra data collection. And the beauty is that you could download the ELSO data in the back end into an XML type file and send that to ELSO so that it can be uploaded for your center at regular intervals. So there wouldn't be double data collection. We use very standardized definitions and core outcomes, some of which we developed for the International ECMO Network, I'll show you. But we harmonize these again, all with ELSO. And again, with the help of Ryan Barbaro, the ELSO registry chair, we wanted to make sure that everything was similar across the current registries that were available. The data we're collecting, probably not surprising to you, include things like baseline and pre-ECMO factors. We have data longitudinally on daily mechanical ventilation, ECMO, vasopressor use, sedation, these sorts of things in the ICU. And importantly, we're looking at complications and outcomes. Perhaps almost more importantly is this idea that we also want to have some longer-term follow-up of patient-reported outcome measures, which are super important to our patients and their caregivers, including things like independent activities of daily living, health-related quality of life with the SF-36, measures of disability using the WHO scale, and things like return to work. And I think more important than anything is the idea that we love to have interested centers reach out to us about joining Index, because it's more than just about data collection and joining a registry. We really feel that this is part of a collaborative network, that we hope that we could build interested investigators together so that we could work together with the data being an important component, but work together to hopefully answer or tackle some of these important questions that are facing us in the field so that we could move the entire field of ECOR, ECMO, extracorporeal support forward. Every center owns their own data, so this again helps to hopefully replace or complement the idea that most centers are already collecting some ECMO data or ECOR data locally because they need to inform their own practices and under quality assurance. And again, any center can then, if they join this collaborative network of Index, they could propose research questions or analyses that use the totality of the data to increase, again, the inferences or the strength of the inferences that can be made, presuming that the question, again, is ethically valid, scientifically sound, and these sorts of things, much like in a similar way that ELSO centers can propose research analyses to the ELSO registry. We plugged in core outcomes that we had developed in a modified Delphi, again, showing you that importantly, other than things like mortality and complications, we're very focused on these patient-important outcomes of life impact. And certainly our patients and their surrogates who sit on these Delphi panels have repeatedly told us that often things that are important to clinicians or things that we think are important to us are maybe not the most important things to patients and their families. So we included many of these in the index registry, which make it a little bit unique from the ELSO registry. And just as a summary, I apologize, I should update this slide. We have over 250 patients in the registry now. We're growing the registry organically. So we've started in Canada and North America, but we're slowly, I'll show you in a second, growing across other regions of the world, including Europe, the Middle East, and Asia, as well as in Australia and New Zealand. This is just a brief summary of the data that's in the registry already. So you can see the average age, many males. Again, because we started with a number of centers that are focused on respiratory failure, we have the vast majority currently in index for respiratory indications versus cardiac or ECPR. And you can see some of the crude outcomes here that are listed. Other sites are in various stages of preparation. And we're happy, like as the months and weeks have been rolling on, we've been slowly but surely increasing our sites. We're currently in contact with nearly 100 sites who are in various states of preparation. 6 sites now are active. Some have just gotten their data sharing and other ethics approval, and many we're still discussing at the moment, including sites in Kuwait, in Europe, and in Asia, including a hospital in Beijing that's already online and beginning to collect data. Our colleagues in Australia and New Zealand had a bit of a head start on us. So because in Australia and New Zealand, there was already a federally mandated adult critical care database called the Adult Patient Database, or APD, that's funded by the government and is required of ICUs to collect. They were able to put index as an extra add-on, if you will, to that infrastructure that was already existing in many ICUs across Australia and New Zealand. And so Carol Hodgson, our co-principal investigator, dubbed this part of Index Excel. They have now over 1,000 patients in their registry. Here again, now that because they have many more centers in their in this part of Index already, there's a sort of a better balance of respiratory, cardiac, and ECPR cases. And these, again, both in Index and in Excel, some of these respiratory cases reflect the use of eCore in various forms with various devices. And again, here you could see some of the crude outcomes that are there. And importantly, again, our idea that these registries can be very important to facilitate research. In Australia and New Zealand, they've already embedded 5 registry trials into Excel already. We're working on that as well here. So both to increase the scope of Index and to embed trials, we're embedding 2 federally funded trials here in Canada, including a new trial looking at CO2 removal to, again, as Kai sort of mentioned, to deliver ultra low lung protective mechanical ventilation called the ULTIMATE study. So we've embedded this trial into Index, and it'll occur in 10 centers across Canada as a pilot study, a proof of concept, before moving to a larger, hopefully international multi-center registry embedded trial in the near future. We also have a trial that's focused a bit less on strict lung protection, and a bit more on the patient as a whole. So with the idea of, we saw a few reports in COVID of using ECMO perhaps in less hypoxemic patients to facilitate early awakening, early liberation, and early rehabilitation, as opposed to strict lung protection. And here where this is a proactive pilot study, which again is federally funded and in collaboration with Berlin Charité and our colleagues in Melbourne, we're conducting a pilot study, which again is embedded in Index and will hopefully progress to a larger study. So again, the silver lining of COVID is that we know this works well, the recovery platform being a real good exemplar of how this has worked very efficiently, and embedding these into adaptive platform trials, which is what we've created here in Toronto, is a platform trial focused on respiratory failure called Practical. And these trials will now use Index, this platform structure, to help the more efficient design and conduct of these studies. So hopefully we can get answers to these questions sooner rather than later. So I want to just finish with hopefully asking any interested people to please feel free to get in touch with us. Kathleen Excond is our fantastic project manager. Her email is here, as well as mine. We also have a generic email for the Index registry, but please, we hope to invite interested centers to come and join our collaborative network, or even if you just have questions about how it's going or how they could join, please feel free to reach out to us. We'd be happy to answer by email and or have a Zoom meeting about that. And we hope that by building slowly but surely this global collaborative, we can, again, greatly increase the efficiency by which we can answer some of these important questions and help move the field of extracorporeal support forward. So thank you very much. I'll just finish maybe, and happy to take questions with Kai on this topic.
Thank you very much. I'd like to thank Professor Fan for this great summary and highlighting the importance of the registries. Again, maybe just to add to this a little bit, this is a registry that is looking at both ECMO and eCore. So the idea really was for us, and we are having discussions with Eddie for I don't know how many years now on this registry, and I really would like to thank him for all his patience with us. As you can imagine, especially since this is a global registries, there are different legislations in the regions, in the countries, and all of that had to go through our lawyers as well, which which made things at times complicated. But it's now there. It is up and running, and I really would like to encourage everybody for the opportunity to participate in this. Not only for us, we're not, but I think really as Professor Fan was highlighting, could be so much benefit for every center participating because you can own the data, you can do research with your own data. We oftentimes have seen in other countries and regions that they want localized data. Basically, okay, you have an Oxirus study that was in France, but then how are things in China? Outcomes may be very different. You are able to do that. You could even think about, sub-analysis for regions, for countries, whatsoever. We really believe there is a lot of value, and we just want to offer that. And thank Professor Fan for setting this up. This really is going to be, I believe, very helpful. There are some questions. One is related to Prismalung still, so maybe I can take that one. How efficient is Prismalung in terms of CO2 clearance, and how many devices would one patient need on average? So maybe you recall the slide, and again, these were in vitro. There was an in vitro testing, and CO2 clearance obviously depends on flow rates and the CO2 level. And in this in vitro testing, there were flow rates of 2, 3, and 400. And there was also CO2 levels, if I remember correctly, of 40, 60, and 80. At 400 ml blood flow rates, the CO2 clearance was above 100 ml for sure. So we believe that is a substantial improvement to what we've seen in other devices or in older technologies. And how many devices would one patient need on average? Maybe Eddie wants to comment on this one as well. We usually have seen something between 2 to 3 devices in one patient, but maybe Eddie, do you have a different opinion?
No, I think that sounds about right, Kai. I think obviously it's very dependent on the patient, their severity, the indication, but I think that makes a lot of sense. And I think certainly as I feel that eCore is moving towards populations of patients with maybe less severe hypoxemia, and certainly in the acute exacerbation of COPD sort of situations, that hopefully some of these patients might turn around more quickly than some of the other more traditional settings in which eCore has been deployed. Sicker patients who might need a longer run, so maybe the number of devices that these patients will need will go down depending on, again, like what their underlying severity or clinical indication might be.
Thank you. All right. I think we are at the hour now, a little over. Again, thank you very much, Professor Fan, for your time and your participation. I would like to thank all the other speakers here as well. I think it was a very informative meeting. I would also like to thank all the other participants for their questions, for their interest. We look forward to seeing you next year again. I again would like to encourage you to maybe send us some topics that you would like us to discuss. Some of them have been mentioned here. Other fluids, fluid management, whatsoever, please let us know if there are any other topics that you think we should highlight in our next meeting. With that, I will close the symposium now. Thank everybody and wish everybody a good evening or good evening, maybe, I guess. Thank you all. Goodbye.